In this PowerPoint, we will be discussing my literature review on the dentofacial effects of radiotherapy on the pediatric population with retinoblastoma. So what is retinoblastoma? Retinoblastoma is a malignant tumor that originates in the retina. It is the most common intraocular cancer in pediatric patients. This cancer can impact ocular health, but also the overall development of dentofacial structures due to its early presentation in children. Leukocoria and strabismus are the most common signs of retinoblastoma. As you can see in this picture, leukocoria means white pupil. The second most common early sign is strabismus, which is hypertropia in crossed eyes. So why is this topic important? There have been advancements in treatments that have improved the survival rates of patients. However, there are still long-term consequences from radiation therapy. Radiotherapy can have alterations on the growth and development of dentofacial structures, particularly in pediatric patients because they're still growing. Consequently, there are significant effects to the dental and maxillofacial components, including teeth, jaws, and related structures, which manifest over time. By understanding the dentofacial effects of retinoblastoma and exploring the management and rehabilitation approaches, we may mitigate these effects to improve the overall quality of life and long-term health of patients. The objectives of this literature review is to investigate the dentofacial effects of radiotherapy in young patients with retinoblastoma by referencing current research, to note management and rehabilitation of dentofacial abnormalities, in particular highlighting orthodontic, surgical, and prosthetic approaches, and also to understand the changes of dentofacial development due to retinoblastoma treatment. So these are my methods. The literature search was conducted to identify peer-reviewed English language articles pertaining to the dentofacial effects of radiotherapy in retinoblastoma patients, focusing on the pediatric patients. There was a manual search that was conducted to identify potential articles from the reference list of relevant studies. The articles were published between January 2003 to December 2023. My inclusion criteria was studies that investigated dentofacial effects resulting from radiotherapy in pediatric population with retinoblastoma, studies about facial growth alterations, odontogenesis abnormalities, dentofacial deformities, management of rehabilitation techniques for dentofacial issues regarding retinoblastoma were included. Exclusion were studies focusing solely on the medical aspects of retinoblastoma genetics or unrelated topics. So after reviewing all the literature, the results were highlighted into kind of a category of alteration of growth, dental development, and craniofacial growth. So those are the three things we'll go over. There are facial growth alterations, which are common consequence of radiotherapy in retinoblastoma survivors. These alterations manifest as asymmetry in maxillary mandibular development, leading to facial disharmony. There's an anterior-posterior skeletal deficiency seen in the maxilla, revealing an angle class 3 malocclusion, severe anterior and posterior crossbite, and posterior open bite, as you can see in this figure on the left. The disrupted growth patterns often resulted in malocclusion, affecting occlusal relationships and contributing to functional challenges. In addition, these patients tend to have abnormal odontogenesis. The potential side effects of radiation on developing teeth differ based on the child's age at diagnosis, the stage of tooth development, the radiation doses and treatment schedules, and the specific area being treated. So it's not every patient, but it depends on how the patients were treated initially with retinoblastoma. This study identified variations in tooth development, potentially affecting the number, size, and morphology of the teeth. As you see in this picture, they're showing some absence of upper permanent teeth and retention of the primary teeth. Lastly, there's the presence of long-term skeletal and craniofacial deformities resulting from the radiotherapy. Irradiation of the face causes the underdevelopment of the orbit, zygomatic bone, and root of the nose, and hypertelorism. The skeletal changes from radiation are caused by its impact on the cartilaginous growth centers, specifically the sutural growth centers of the maxilla and the condylar cartilage in the mandible. Because the radiation impacts the maxillary growth center, there's bilateral hypoplasia of the maxilla, regardless of the location of the retinoblastoma. The hypoplasia of the maxilla is reflected in the concavity of the profile. As you can see, she kind of has this concave profile. Although the deficiency of the maxilla is present bilaterally, the midfacial asymmetry is unilateral on the left due to the enucleation of only the left eye. Besides the dentofacial abnormalities, there is also the topic of psychosocial repercussions. The altered facial appearance coupled with functional challenges contribute to the psychosocial burden experienced by these individuals. The dentofacial abnormalities, particularly those affecting occlusion and oral function, pose challenges in everyday activities. Difficulty in chewing, speaking, and maintaining oral hygiene were reported as common issues, adding a practical dimension to the impact on patients' daily lives. So now that we know the effects of radiotherapy on the dentofacial structures and the craniofacial structures, I'm going to go over management and rehabilitation to understand how they go about treating these patients post-radiotherapy. First, they usually get orthodontic treatment. Orthodontic treatment should be carried at least 2 years after completion of radiotherapy. It is important to use low forces to minimize root resorption or further root shortening and to complete treatment early. This treatment is really aimed to correct malocclusion, align teeth properly, and improve occlusal relationships. The orthodontic strategies were tailored to the specific needs of each patient, considering the extent of dentofacial abnormalities and the desired functional and aesthetic outcomes. Next, they usually get surgical interventions, which is essential to fixing the skeletal and craniofacial deformities. Due to the hypoplasia of the maxilla, orthodontic surgery of the maxilla is recommended for the Fort 1 osteotomy. And after surgery, these patients still tend to need prosthetic rehabilitation. Due to missing teeth and all the other stuff, patients with retinoblastoma usually have missing teeth or extraction due to the extensive radiotherapy, so they usually require rehabilitations to replace those missing teeth. So from this, we can tell that there's an important integration of orthodontic, surgical, and prosthetic interventions in order to solve these diverse challenges and to fix all these abnormalities. The literature review highlighted the multifaceted nature of the dentofacial abnormalities observed in retinoblastoma patients treated with radiotherapy. These abnormalities encompassed disruptions in facial growth, variation in odontogenesis, skeletal and craniofacial deformities, and functional limitations. The complexities of these abnormalities demonstrates the need for a comprehensive understanding of their etiology, progression, and impact on patients' overall well-being. These are my references. Thank you so much for listening.